HIPEC is also, known to be hyperthermic intraperitoneal chemotherapy. It's a local regional treatment of the peritoneum at the time of surgery. And this has been proposed and done for many years now, not only for ovarian cancer, but for other solid carcinomas of the gastrointestinal tract. And in the past decade has been proposed and done more often in the setting of ovarian cancer patients. HIPEC often, the word when patients come to our clinic sounds very fancy, and patients confuse this word with high tech a lot of time, although it really has nothing to do with high technology. It's not cutting edge technology in the OR. It's simple perfusion of the peritoneal cavity with heated chemotherapy. And some surgeons and hospitals do promote this treatment for ovarian cancer as a cure and maybe overstate the benefits. Some experts who are using this treatment often are recommending to use this in all settings of our patients with ovarian cancer, be it in the primary setting or in the recurrent setting. And I hope that today we can a little bit talk about, where the science and the research stands and how applicable this treatment is for our patients. Now, this was just published last year. It's a decision-making analysis of hypothermic intraperitoneal chemotherapy in ovarian cancer. Basically, a survey done by executive committee members of the Peritoneal Surface Oncology Group, also known as PSOGI. And these 12 experts weighed in on how important HIPEC is for the treatment of ovarian cancer patients. And among those experts, HIPEC, according to those experts, plays an important role in the primary and recurrent setting of ovarian cancer, and that the extent of disease, the peritoneal carcinoma index, is the most important criterion in this decision. Now, before going into this in detail, let's talk about the rationale for hyperthermic intraperitoneal chemotherapy. We know from randomized trials that the intraperitoneal application of chemotherapy does work in patients with ovarian cancer when given postoperatively successively in 6 cycles of postoperative intraperitoneal chemotherapy and combining it with intravenous chemotherapy. Not in the OR and not hyperthermic. There have been 3 trials who showed a survival benefit. And this benefit was also seen in patients who were not able to receive all 6 cycles, but less than 6 cycles. But giving the chemotherapy intraperitoneally after surgery in multiple cycles was associated with a higher rate of morbidity, and it was underused even in high volume centers in the United States, because logistically this was challenging. There were a lot of patients who complained about abdominal pain and more complications, so it never really materialized in a widespread use. So given the chemotherapy in the OR means that there are no adhesions. It's a highly standardized procedure while the patient is under anesthesia. It's already a safe environment where a patient is not experiencing any pain, is under anesthesia. There is no interval between surgery and chemotherapy. The first cycle, if you want, is being given right then and there with no delay in treatment. And by heating the chemotherapeutic agents, some chemotherapeutic agents are enhanced in their effects by increasing DNA cross-linking and tumor penetration, especially platinum compounds, which are frequently used in patients with ovarian cancer. Now, in 2019, this huge randomized trial was published in the JCO. John Walker published this and reported this NRG trial, where patients with primary ovarian cancer, advanced stage ovarian cancer, were randomized to either receive standard intravenous chemotherapy with paclitaxel and carboplatin and bevacizumab. And this standard treatment was compared to two regimens where intravenous chemotherapy was also combined with intraperitoneal chemotherapy, either cisplatin or carboplatin, and all three arms did receive bevacizumab as a maintenance treatment. And in this large 1,500 patient trial, we did not see any difference between intravenous and intraperitoneal use when adding bevacizumab as a maintenance treatment. And the postoperative use of intraperitoneal chemotherapy has since then significantly declined. It was already not used very frequently because of the previously noted side effects and logistical challenges. But this trial really is putting postoperative local regional chemotherapy out of favor in many institutions in the United States, including in our institution. We can't talk about ovarian cancer without mentioning how important the molecular analysis is of our patients, and we can't talk about ovarian cancer without using the word homologous recombination anymore, because it does play an important role in treatment and also prognosis of patients. And we know that about almost 45% of patients either have a germline BRCA or BRCA2 mutation, or have homologous recombination deficiency, which is a result of possibly somatic mutations or other hypermethylations or other molecular changes. And this is important to know because it's exactly these patients who benefit extremely from platinum-based chemotherapy, but also from a new compound of PARP inhibitors that are given orally as a treatment and as a maintenance treatment for those patients who come through our doors. 4 large randomized trials have demonstrated improvement in progression-free survival for patients treated with PARP inhibitors, especially robust data in patients with BRCA mutation and homologous recombination deficiency. So really now, where do we stand with HIPEC? Which drugs should we use? Is the toxicity clear? And what's the evidence for effectiveness? And in which disease setting should we use HIPEC, knowing much more about the molecular composition of our patients? And we have looked at cisplatin used in patients with recurrent cancer. We wanted to find a good dose of cisplatin used, and these were all patients with recurrent platinum-sensitive cancer. And we did a nice phase 1 trial where we looked at the pharmacokinetics, and you can see really during 90 minutes after removing the tumor and then giving cisplatin in a heated form for 90 minutes, we can see an extremely favorable pharmacokinetic profile of cisplatin, with extremely high doses of cisplatin measured in the peritoneal cavity, and very low absorption of cisplatin into the systemic compartment. And the ratio of cisplatin in the peritoneum versus the blood is 19.5, so it's 20 times higher dose density in the peritoneal compartment, and very low systemic exposure, which explains a very safe hematologic profile of given cisplatin intraoperatively, intraperitoneally, because just little amounts of this drug are being reabsorbed. So we did not see a lot of systemic side effects from this one dose given intraperitoneally. And we've established a dose of 100 milligrams per meter squared to be safe in patients who are otherwise fit to undergo secondary cytoreductive surgery. We also looked at the tissue before and after HIPEC. We wanted to see if 90 minutes is enough for the cisplatin to penetrate into the cell and interact with its substrate, the DNA, and form DNA adducts, which then result in the apoptosis and death of the cancer cell. And we can see on the lower in the lower row that after HIPEC, all those blue dots are cancer cells, cancer DNA, and all those red dots are cisplatin DNA adducts. And when you overlay these two, you can see that the cisplatin penetrates in the majority of cancer cells and forms DNA adducts. So 90 minutes is definitely enough for the cisplatin to interact with its substrate. We have done the same thing with carboplatin in our recently published trial, and we can see that carboplatin as well is very favorable when applied peritoneally. The high doses of carboplatin can be reached and plotted against the low dose of systemic reabsorption, but the ratio between the peritoneal compartment and the systemic compartment is 2.3, so it's lower than with cisplatin. So a little bit less favorable from a pharmacokinetic standpoint than cisplatin. We've also looked at, what happens with the tumor tissue and the normal tissue before and after giving heated chemotherapy on a molecular level, and we did find that the responses of the tissue, be it normal or tumor tissue, is different. The normal tissue reacts after 90 minutes with a strong immune response, whereas the tumor tissue has a differentially expressed response with reacting mostly with heat shock protein folding. So this is something interesting to see, the difference between normal and tumor tissue, and see if we can use this to guide our treatment in the future. Now, when we look at the data of HIPEC, unfortunately, most studies are retrospective case control studies. We have really very limited prospective evidence of the use of intraoperative heated chemotherapy. The problem with those studies, although many patients have been treated with HIPEC, is that it's not randomized. And when you look at the settings of the disease, you can often see that the disease settings are not clearly defined, or are both in the primary and the recurrent. When you look at the HIPEC drugs used, there's multiple combinations or single agent therapies that are used. The doses are not really defined in many of those studies clearly. And when you look at the progression-free and overall survival between 10 months and 60 months, it's not really much different than what we see in studies of ovarian cancer patients, be it in the primary or recurrent setting, without the use of HIPEC. The serious complications are and mortality rates vary between 20, 30, 40% mortality between 0 and 7%. This is also something that looks familiar when you look at many surgical studies of ovarian cancer patients without the use of HIPEC. So what we need is clearly randomized studies, and this was published in 2018, the really very first well-conducted and well thought of prospective study in patients with stage 3 ovarian cancer only, who received neoadjuvant chemotherapy, 3 cycles of carboplatin and paclitaxel. And once they had stable disease, they were randomized to either have interval debulking surgery or interval cytoreductive surgery, followed by 3 additional cycles, or they were randomized to have interval cytoreductive surgery with HIPEC, and the drug used was cisplatin at a dose of 100 milligrams per meter squared, followed by 3 additional cycles. When this study was conducted and performed, no PARP inhibitors were used, and no bevacizumab was used, and no immunotherapy was used. So this is clearly not the contemporary setting of treatment that we're using nowadays. But even though we can see that, and this is the first randomized study that in this particular patient population has shown a benefit in favor of this 1 dose of 90 minutes of cisplatin given operatively during interval cytoreductive surgery, with an improved progression-free survival and an improved overall survival. Now, although this study is very well done, I do want to point out that the number of patients in each arm was 122 or 123, and that in the surgery group, 110 out of 123 patients, and in the experimental group, 99 of 122 patients had an event of disease recurrence or death. And when you look at the subtypes of the histology here, you can see that there were patients who had carcinosarcoma, more in the surgery group, mucinous cancers, clear cell carcinomas, or low-grade serous cancers were all a little bit in favor of the HIPEC arm here. And you can see that if you look at the numbers itself, that those 14 patients with those rare histologies which would favor the HIPEC arm are there, that this is really, the difference is a very narrow one, and this is one of the criticisms of this study, that maybe the number of patients was a little bit low to really show a robust difference here. Just wanted to point this out. Nevertheless, and we at our institution use cisplatin at a dose of 100 milligrams per meter squared, especially and only in this indication of patients who had neoadjuvant chemotherapy and had stage 3 disease. And this is also part of the NCCN guidelines. Now, another retrospective study just recently published from the Chinese peritoneal oncology group here. They have looked at the primary cytoreductive setting, so patients who have not received neoadjuvant chemotherapy, and out of those 789 patients, about 400 patients received HIPEC, and about 150 or 60 patients were treated with primary cytoreductive surgery alone. And interesting here, the investigator used cisplatin as intraperitoneal chemotherapy in the OR, but they all use it at a dose of 50 milligrams per meter squared over 60 minutes. So it's different than what was published in the randomized trial from Europe. And what's really important here, and I think significant, is that in this retrospective analysis, they repeated the treatments on day 1, 3, and 5 after surgery. So patients had surgery, had chemotherapy in the OR for their primary disease, but they were, followed in the hospital, maybe in the ICU. It's not unclear, and were treated with 3 successive doses of cisplatin while inpatient and probably under anesthesia. So this is really a very logistically challenging treatment. And in this retrospective studies, patients who received this treatment with successive cisplatin applications had an improved median overall survival over those who did not. And this was also visible in patients who had a complete resection of all visible disease. But since this was a retrospective study, we need answers in the primary cytoreductive setting in a prospective form, and this trial is just ongoing in Europe, where patients with stage 3 disease, ovarian cancer, who go to the OR for primary cytoreductive surgery are randomized 1-to-1 if they had almost complete or complete cytoreduction of all visible disease. They are randomized to either have HIPEC with cisplatin at a dose of 100 milligrams per meter squared over 90 minutes or no HIPEC. And all patients postoperatively go on to undergo 6 cycles of carboplatin and paclitaxel chemotherapy. And in this study, and this is different than from the previous study, bevacizumab and PARP inhibitor maintenance treatment is allowed as per standard guidelines. And the follow-up here with CT scans is very strict. So this is going to be the answer for the role of hypothermic chemotherapy in the more contemporary setting of drugs used postoperatively. And once this trial is finished, we will know as to whether HIPEC with cisplatin plays a role in the primary cytoreductive setting. Now, in the recurrent ovarian setting, there's again multiple retrospective studies who suggest that HIPEC is beneficial for patients who undergo surgery for the recurrent disease. And when you look at our retrospective data of all patients who selected to undergo secondary cytoreductive surgery for recurrent platinum-sensitive disease, and this is in the era before we use HIPEC, we can see in this select group of patients a median overall survival of 80 months, which is really fantastic when you think about that these patients all had a recurrence, but these are clearly selected patients who meet the criteria for surgery, who have a long disease-free interval, have resectable disease on preoperative imaging. But in this select group, without HIPEC alone, we have overall survival of 80 months. So really, the use of HIPEC should be limited to patients, and after we know that studies show a benefit. And this is a randomized study that was published in 2014 from Greece here. 60 patients with platinum sensitive and platinum resistant disease were randomized to hypothermic chemotherapy or not. And in this study particularly, the regimens were different for the disease setting. So this cisplatin with paclitaxel was used as a combination for platinum-sensitive disease, and doxorubicin with mitomycin was used in patients with platinum-resistant disease. And this study showed a benefit in favor of patients who were treated with HIPEC, but the benefit was only pronounced, interestingly, in the patients who had platinum-resistant disease. Now, the study was criticized a lot because there was no, standardized protocol of how the patients were treated post-operatively. There was a lack of power with only 60 patients in each arm, and also the inclusion of patients with platinum-resistant disease really is questionable as well. So we're not quite sure if we can just go by this one trial and offer HIPEC, especially in the combination treatment, to all our patients with recurrent disease that we select for surgery. And we have then in our institution put in a concept for a phase 2 randomized trial in patients with platinum-sensitive recurrent ovarian cancer. We specifically focused in on patients who had a platinum-free interval of 60 to less than 30 months, because we know that if you have a very long platinum-free interval of over 30 months, the outcomes are excellent. And we also selected patients who met our criteria for resectability, and we included 117 patients in this study. 9 of those patients were excluded preoperatively, and since our randomization process was in the OR, we opened an envelope after we were able to remove all visible disease or only leave minimal disease nodules of less than 5 millimeters. We had to exclude another 11 patients where we were not able to remove all visible disease to less than 5 millimeters. And then we randomized to either have secondary cytoreductive surgery alone, followed by 6 cycles of standard platinum-based chemotherapy, or secondary cytoreductive surgery with carboplatin, HIPEC used at 800 milligrams per meter squared, followed by 5 cycles of postoperative chemotherapy. We really wanted to make it difficult for the HIPEC arm to win this, because it's another 90 minutes of OR time, anesthesia time, and we wanted to see a benefit and counted this first cycle of carboplatin towards the postoperative chemotherapy. Important in this study that was just published this year at the JCO, no maintenance treatment was permitted, so no PARP inhibitors or no bevacizumab was permitted. This was all a result of this being a concept that was put in 2013 when those treatments were not standard of care. We checked for 30-day postoperative toxicities. We did tumor assessment via CT scans or MRI scans every 6 months in the first 24 months. And we obviously did clinical assessment and CA-125 measurements every 3 months. We tracked all patients postoperatively, and the majority of patients received carboplatin and liposomal doxorubicin here as their postoperative treatment strategy. And over 90% completed the assigned postoperative intravenous chemotherapy in both arms, so there was no difference, no delay of treatment in patients who were randomized to HIPEC. When you look at both groups, 49 in each arm, you can see that there was no difference in age or histology. Most patients had high-grade serous ovarian cancer, and the platinum-free interval was over a year in 69% of patients. About 20% of patients had a BRCA germline mutation. But where we saw a significant difference was obviously in the OR. Patients who were randomized to HIPEC with carboplatin had, on average, a 2 to 3 hour longer surgery. The other difference that we observed was in the amount of bowel resections used. Patients who were randomized to HIPEC had a lower rate of bowel resections. This was significant. Although not significant, the amount of patients who had a complete resection of all disease was 94% in patients in the standard arm and 82% in patients with a HIPEC arm. This may have to do with the fact that we were able to randomize intraoperatively after removing disease to less than 5 millimeters, and it's possible that intraoperative bias or the fear of complications of a bowel resection has resulted in us maybe shying away from a bowel resection and leaving some small dots behind. This is one explanation for why there is a difference in bowel resections and complete gross resection rates. Nevertheless, the complications were the same in both arms, and the length of stay was just a day longer on average in the HIPEC arm. Please excuse the busy slide. This is a slide. This is, again, the adverse events listed here. Really, we cannot see a difference or a signal towards a higher complication rate in patients who were treated with HIPEC. There is no or minimal systemic adverse events. All events that we have seen here were a result of the surgical procedure itself. And when we look at the postoperative regimens used and the pattern of recurrence, there was no difference in recurrence pattern in both arms. You would assume that maybe patients who were treated with intraperitoneal chemotherapy had less frequently recurrence in the peritoneum, but that was not the case. And when you look at progression-free and overall survival, there is no significant difference in patients who had chemotherapy with HIPEC intraoperatively versus standard of care. In fact, it looks like the curves are a little bit worse for patients who were treated with HIPEC, but this was not significant. And this study clearly shows that in patients selected to undergo secondary cytoreductive surgery for platinum-sensitive disease, the use of 90 minutes of carboplatin did not result in improved outcomes. And even if you look at the subgroups here, again, this is obviously only hypothesis generating, but we wanted to look at those patients who had a BRCA positive mutation or had a longer platinum-free interval. You cannot see a subgroup that benefits from the use of HIPEC. When you look at the 11 patients who were excluded from the randomization process because they were not, we were not able to remove all visible disease or most of the visible disease, those patients really had a progression-free survival that was very poor, of 10 months, and an overall survival of only 30 months. This was much less than what was observed in our patients who entered the study. Regardless of HIPEC or not, the progression-free survival was 15 months and the overall survival was 60 months, so 5 years. This is really comparable with the big studies that have looked at the role of secondary cytoreductive surgeries. And I'm listing those studies here. The GOG 213 was a big randomized study that randomized patients with platinum-sensitive recurrent disease to either have chemotherapy alone or surgery followed by chemotherapy. In this study, bevacizumab was used very frequently. Then there is the German study, the desktop study just published or will just be published in the New England Journal of Medicine. This study showed a benefit in favor of secondary cytoreductive surgery, and the Chinese study as well in favor, whereas GOG 213 really did not show a benefit in favor of surgery. I listed those studies and just listed our randomized trial here to the right. While maintenance treatment was allowed in GOG 213 desktop and the SOC1 trial, it was not allowed in our trial, and we really had a cutoff of platinum-free interval of less than 30 months. We did not want to overrepresent the best prognosis group here. And when you look at the OR time, obviously our OR time was much higher because we used HIPEC. The other 3 studies did not use HIPEC. And bowel resection rates were in generally performed more frequently in our study because we probably excluded the very well players here from this HIPEC study. And when you look at the overall survival of 60 months in our study, it's comparable to GOG 213 and desktop. Again, those and SOC1 who did not use HIPEC but used other strategies, including bevacizumab or PARP inhibitors, which we know increase or improve the progression-free survival significantly between 3 and 15 months, depending on the germline status or the BRCA status. So really, so far in the secondary cytoreductive setting, in the recurrent setting, we don't have very good data to support HIPEC. There's a lot of unanswered questions regarding HIPEC, which drugs to use. Is it the drug that does the difference? Is it the heat? Is it the early chemotherapy? Also, we still don't know if we can support the notion that we should give HIPEC to every patient who undergoes surgery for advanced ovarian cancer, either in the primary or recurrent setting. So in conclusion, HIPEC is safe for sure. It's been tested multiple times, especially with cisplatin and carboplatin. It's certainly not a cure. It could be an adjunct, and it works well in the interval cytoreductive setting after neoadjuvant chemotherapy for stage 3 patients. It improves progression-free and overall survival, but certainly this needs to be confirmed in a more contemporary treatment setting using PARP and bevacizumab and immune therapy, which is really changing the landscape. There's no robust data supporting HIPEC in the primary setting, yet we need to wait for the study that's ongoing. In our randomized phase 2 study, carboplatin really did not improve outcomes in patients with recurrent ovarian cancer. What was the most important prognostic factor was the adequate surgery with removal of all visible disease or leaving minimal disease behind was the most important prognostic factor. And certainly more robust data is necessary to see how to best incorporate HIPEC for our patients. So I would really thank you for giving me the opportunity here to present my data and my opinion on HIPEC. I really want to thank my colleagues in Mexico and my colleagues here, and I'm open for questions. Thank you so much.
Thank you very much, Oliver. It was a great presentation. We have several questions. Most of my questions, you had already answered them. Basically, are the same. What's the best scenario? Which are the best patients? Are the same questions that you already have. So we can start with our Q&A section. And Dr. Salcedo, do you have any questions?
Yes. Good morning, Dr. Oliver.
Good morning.
For your presentation, we appreciate we can talk to you about this topic. I have one question, well, no, many questions, but after the result of your trial, do you think the recurrent disease in ovarian cancer is a good disease setting for another trial with another drug or in different population? This question is related also on the results of GOG 213 and DESCOP, where the secondary cytoreduction is in debate. What do you think about this?
Yeah, I think this is a very good question. So certainly carboplatin used intraoperatively did not help our patients, so should not be used in the secondary cytoreductive setting. Maybe another drug is going to be better. Maybe cisplatin has a more favorable profile. This remains to be seen. There is even a question if we should use secondary cytoreductive surgery at all for our patients with recurrence in the platinum-sensitive setting. As you've said, GOG 213 did not show a benefit in favor of surgery. However, this trial was designed and did not have pre-specified selection criteria. And I do think that selection is very important for our patients with recurrent disease, and selection includes patient general performance status, the platinum-free interval, and the extent of disease. If you have a patient with a long platinum-free interval with oligometastatic disease or minimal disease, and this patient, in my opinion, is going to benefit from secondary cytoreductive surgery much more than a patient who has a short progression-free platinum-free interval and ascites and is symptomatic. So I think selection is really important, and the desktop trial has shown a clear benefit in favor of surgery. So did the other trial from China, both of which had selection criteria for secondary cytoreductive surgery. But HIPEC really should only be used, I think, in my opinion, under the umbrella of clinical trials. So far, there is no good evidence to use it off protocol.
Even though the numbers are relatively high, the numbers of patients treated with this modality, even though I think, yes, and this is the problem. I think a lot of people publish their institutional results and they use drugs intraoperatively, but really when you look at the randomized data, I don't think we have a very strong support there. So I think certainly that it's safe, but I'm a little bit doubtful until I see a randomized trial that clearly shows a benefit. So even though in our institution we have put on patients with recurrent disease into the study, but since the study has been published, we're not using HIPEC intraoperatively in patients with recurrent disease. We have a couple of questions from the audience. One is, it was not very clear in your presentation, what is the role of BRCA1 or 2 mutations in relationship to the HIPEC therapy? Is there any relationship or not?
Yeah,
those patients with mutated BRCA are doing better or worse?
It's a very good question. Initially, we thought that probably maybe these patients are going to do best because if you have a BRCA mutation, you're more sensitive to platinum based treatments. But when you looked at our subgroup analysis of 20% of patients who had a BRCA mutation and had HIPEC, they did not do any better than those who had a BRCA mutation and had surgery alone followed by platinum-based chemotherapy. So this subgroup did not benefit from HIPEC. Now, this is all subgroup analysis. It's really unplanned, so I can't comment much more, but the signals are not what we have anticipated. So I can't really tell you that this subgroup is more susceptible to HIPEC at this point. And our subgroup analysis did not matter. It did not show any benefit. And in the big European trials, we don't know who had a BRCA mutation or not. This was not part of their study. It was not universally tested for. So it's a good question, but it's unanswered. In our study, it did not matter.
And that probably would be a little bit difficult to address this point because of the low proportion of patients with BRCA mutated cancer, right?
Yes, I think it's. I mean, you can probably in the phase 3 trial that is now ongoing in Europe, where again I think over 500 patients are planned in the primary cytoreductive setting. In this particular study, BRCA mutations or BRCA testing is performed uniformly, and PARP inhibitors are allowed as well. So in this study, I think we will be able to see a better or a more robust subgroup analysis that can answer this question.
Another question from the audience. They ask, in your institution, what would be the recommended drug and the dose recommended for HIPEC?
We would recommend cisplatin at a dose of 100 milligrams per meter squared. That's what we use here off protocol in the neoadjuvant chemotherapy setting who undergo interval cytoreductive surgery. We have this dose is very safe if patients are healthy, if patients don't have pre-existing renal conditions, and also if patients have normal labs preoperatively and are not insulin-dependent diabetic patients, because they tend to have pre-existing renal insufficiencies, and cisplatin can make it worse. But we use 100 milligrams per meter squared in patients who have high normal creatinines preoperative. We dose reduced to 80 milligrams per meter squared.
And is this drug recommended independently of histology?
Good question. Well, you know,
would you use this for mucinous tumors, or would you change the regimen? Yeah,
for mucinous tumors, I think we would probably not use, if we know it's a mucinous carcinoma, it's often, you know, not really known beforehand, but if it's clearly a mucinous carcinoma, then we would probably use a different drug. Then we would probably use mitomycin or a GI regimen. Quite frankly, it doesn't happen that often. Mucinous carcinomas are extremely rare, and probably cisplatin can be used as well in mucinous tumors. There's little data to say that doesn't work. We are now initiating a really combined with MD Anderson under the leadership of Michael Fromowitz from MD Anderson, a trial in patients with recurrent mucinous ovarian carcinomas, where we're going to use cisplatin as the drug, but at a very high dose of 100 and I think 160 milligrams per meter squared, because that's what their GI surgeons use. So I think it's a very good question, but it's difficult to tell you different regimens for different subgroup analyses, because we have little randomized or prospective data to begin with. But the question is good. I think the drug and the dose matters, and we still have to find out what's the best fit for which histology.
Another question from the audience. I think this is going to be a little bit challenging. What would be the best choice for those patients with platinum-resistant disease, if there is?
I love the question, and it comes up here often. So it's a challenging question. As you know, platinum-resistant ovarian cancer patients, the vast majority of those patients probably don't benefit from cytoreductive surgery at all. And I'm saying that because there has been really in the 80s, 90s, good data to support that, because the true platinum resistant patient that progresses during first-line chemotherapy or never normalizes the CA-125, never goes into remission and comes back, they really have a very different prognosis and profile, and we typically don't take those patients to the OR. Now, there's other platinum resistant patients, who had surgery and chemotherapy, but during the surgery, tumor was never really removed, let's say from the liver or the diaphragm, and this is the only thing that's still left and slowly growing. And they're technically considered platinum resistant, but they're probably a different prognostic profile. In those patients, I still would favor platinum as chemotherapy, because I think the world or the molecular scientists are going away from this term platinum sensitive versus platinum resistant. I don't think this is going to be a classification in the near future, because it really just gives us information about the platinum-free interval. Doesn't tell us really is this resistant or not when you give it. So I think if you choose to take select a patient with platinum-resistant disease to the OR, if you think this is the right thing to do, then I still feel that intraperitoneal platinum-based compounds such as cisplatin have a very good pharmacokinetic profile. They penetrate, and they should be used going forward.
Only if the tumor is removed, right?
Yes. There's people who talk about just giving the chemo intraperitoneally without removing the tumor will reduce ascites or symptoms, or giving HIPEC in platinum-resistant disease. I don't see a good benefit for that. I don't really have good data to support that it really improves progression-free and overall survival or quality of life. I'm not aware of this data.
Dr. Salcedo?
Yes, Doctor, what is your perspective of HIPEC in the future? Because there are new drugs in the landscape of treatment of ovarian cancer, like PARP inhibitors or anti-angiogenic.
Yeah, very good question. I've been dealing with local regional treatment for the past 15, 20 years, and I put a lot of effort in it. But these new drug compounds, the PARP inhibitors, and certainly the immunotherapies that are on the horizon are changing the way we're treating our ovarian cancer patients. They have a great and meaningful impact on progression-free survival and overall survival. And I think patient selection, molecular subclassification of patients are going to be important going forward. It's going to be hard, quite honestly, to show a significant, meaningful benefit of one dose of chemotherapy applied during surgery. When you think about what those new drug compounds can do when given as a maintenance treatment post-operatively. But I still, on the other hand, I do believe in the data that was published in the 80s, 90s, early 2000s of local regional chemotherapy. I do think there is a subset of patients that benefits a lot from a peritoneal treatment. And I think the next 5, 6, 7 years are going to show more randomized trials and maybe are going to be able to tell us who are the patients who benefit most from hypothermic intraperitoneal chemotherapy and who are those who don't.
Thank you.
At this moment, HIPEC could be just, or the indication is just for recurrent disease would be the best scenario, or for interval, or upfront, or.
So at this moment at our institution, we use HIPEC off protocol as a standard only in the setting of stage 3 disease after neoadjuvant chemotherapy. We do not use it in the primary cytoreductive setting off protocol. We do not use it in the recurrent setting off protocol. We have protocols for the primary setting. We're participating in the European study, and but we're really using it as a standard of care only in patients who have neoadjuvant chemotherapy, which is a significant number of patients. When you look at our institution, I think 30 to 40% of all comers undergo neoadjuvant chemotherapy. So if you have stage 3 disease and you have responded well, you're an ideal candidate for that.
Great. And do you consider the nutritional status in relation to complications after surgery?
Yeah, all the time. The nutritional status, the albumin, preoperative albumin has been shown to be super important for all our surgical patients. But if you deem a patient fit for surgery, then the dose of HIPEC is not going to make a difference. So if you're fit for surgery, if your nutritional status is good, then your risk of major morbidity and mortality is acceptable. Mortality is very low, and morbidity is what we expect in our patients without the use of HIPEC. But the nutritional status is really important when you look at all the surgical data and all the surgical trials and predict post-operative outcomes. Yes.
Excuse me, do you have any limitation of age for made HIPEC in any patient?
No. If you are as a good candidate for cytoreductive surgery, we don't make age cutoffs. Our cutoffs are really based on renal pre-existing conditions, insulin-dependent diabetes. These are our cutoffs. And intraoperatively, obviously, there's been a long surgery or a lot of blood loss. Then adding another 90 minutes may be too risky. Sometimes we intraoperatively decide not to treat.
From your point of view, as you have mentioned a couple of times during your talk, this treatment is not the cure. Therefore, why to use it if it's not a cure?
Yeah, I mean, when I say it's not the cure, it's maybe a little bit too pessimistic. We do see 20%, 25% who are in remission for 5 years or longer. If the argument is like this, then why are we using anything? The majority of our patients recur with ovarian cancer, advanced ovarian cancer. Unfortunately, that's the case. But I do think if we see a benefit in terms of prolonging the time of remission significantly, or prolonging survival significantly, I still think it's a very low risk treatment that in the right setting should be used if we feel that we can prolong progression-free survival and overall survival. But certainly some patients are cured. But I made this statement initially because patients often come to my clinic and they have heard and read about HIPEC, and they think that this is the most important treatment strategy in their for their disease. And if you look at the data, unfortunately, that's not the case.
Great. Last question, Rosa?
Yes. Do you think it's necessary another trial during interval surgery with the use to other systemic treatment? Because you show us that PARP and bevacizumab will not use in the Vandriel trials.
Yes. Was your question if I believe that surgery is going to play an important role, or was that your question? Yeah, I think I think surgery plays a very important role. When you look at all the data, the best outcomes are seen in patients who had a complete cytoreductive surgery. Even in our phase 2 study, the most important prognostic factor was the ability of us to remove all visible disease. And the patient, our recurrent setting on average lived 5 years or longer. And we already took away the best players. And when we looked at those patients who had residual disease versus not, we can see that the resection plays an important prognostic role. I really truly believe, although we have PARP inhibitors and bevacizumab and new compounds are on the horizon, that for our advanced cancer patients, the intervention of surgery, if the patient is fit for it, is a crucial and still important prognostic tool. And I have not seen a lot of patients in my practice who survived 5, 10, or 15 years who did not have part of their treatment being surgery. Maybe there are a few, but it's the most patients who are long-term survivors had surgery as part of their treatment. And I do believe even with PARP and bevacizumab that a high-quality surgery is an important prognosticator for our patients.
We thank you very much, Professor Zivanovic, for your talk. It was a fantastic talk on these techniques and this and seeing your results. And we hope we can have you sometime here in our institution and in another masterclass
Thank you so much.
HIPEC.
Anytime, it's a great pleasure, and I'm really honored to be able to share our data, and I hope that we'll see each other in person. Thank you so much.
Muchísimas gracias a todos. Doctora Salcedo, muchísimas gracias por acompañarnos el día de hoy. A todos nuestra audiencia, les agradecemos mucho su atención y nos vemos pronto en la próxima sesión. Muchísimas gracias. Thank you, Oliver. Have a great day.
You too.